All right, guys, so we're going to be talking about the second part of chapter 19, the cardiovascular system. We're talking about the heart. This is going to have to do with the function and the cardiac output. So make sure that you really understand the anatomy of the heart before you move on to this. So we're going to talk about the cardiac conduction system, the cardiac cycle, how to calculate cardiac output, any effects of exercise on cardiac output and heart rate. We're going to name some of the centers of the brain that control heart rate and describe their function. Okay, so just a quick review of the microscopic anatomy of cardiac muscle is that cardiac muscle, again, is short, thin, straight, or branched cylinders. It does have a myofibril structure and has A bands and I bands, or the dark bands and the light bands. Those are going to create striations. They have T tubules within them that are going to conduct electrical impulses to the interior at Z disc. This is very similar to the skeletal muscles. However, it has a sarcoplasmic reticulum, but the sarcoplasmic reticulum does not store much calcium. That actually is going to enter from the outside of the cell. That causes us to have a slower contraction. Okay, there's a single central nucleus. Sometimes there's two or more, but most often just a single central nucleus. And we have what are called intercalated discs. The intercalated discs are going to connect the cells, and that allows them to have an electrical link by these gap junctions that are made of connexons, sorry. So as far as our cardiac physiology, the heartbeat is just a single contraction of the heart. And the heart contracts in series. So the atria are going to contract together and the ventricles are going to contract together. With two types of cells within the heart. We have autorhythmic cells, meaning that they are self-excitable. And when we do what's called an EKG, we're actually showing their activity. And then we have contractile cells. 99% of our cardiac muscle cells are contractile cells, meaning that they are not excitable or self-excitable. Okay, so we have within the right atrium, we have what's called the SA node. It's called the sinoatrial node. That sinoatrial node is going to sort of start the process, and it's going to send the signal, the electrical impulse, down through the AV node. These would be action potentials that we're sending. The action potential is going to go to the AV node or the atrioventricular node. That's going to go down through the bundle of His, and then it's going to divide into the Purkinje fibers to go around the right and the left ventricles. Okay. So we have what are called autorhythmic or pacemaker cells. These are found within the SA or the AV node. Here's that SA, here's the AV node. Okay. And then we get that branching out. Okay. The SA node and the AV nodes, these are very excitable, and they have what's called an unstable resting potential. So hopefully you can take yourself back to action potential that you learned way back when we talked about potentially muscles or the nervous system. Okay. So that resting potential is unstable, meaning that they slowly drift toward threshold, meaning that they're sort of leaky cells, right? If you remember that we had to have sort of a stimulus to start this process when we talk about skeletal muscle cells. We had to have a stimulus to start the influx of sodium, right? And then at threshold, we would open up those voltage-gated channels. Well, in this case, we actually don't have to have that stimulus. We have sort of leaky sodium channels within these particular SA and AV nodes. And because of that, leaky channels is that we're sort of moving towards threshold. Once we hit threshold, then we're going to get that rapid depolarization with the flood of sodium moving into the cells. Okay. Those sodium channels are going to close. Now, kind of a difference here is that we have what are called slow calcium channels. Those slow calcium channels give us a plateau, and that plateau actually allows the heart to be able to refill with blood. So this is a comparison of the skeletal muscle and the cardiac muscle, and I would encourage you to kind of take some time and do this on your own. See if you can compare and contrast skeletal to cardiac muscle. So the cardiac conduction system, we have this SA node or the sinoatrial node. The sinoatrial node sets the sinus rhythm of the heart. It's the pacemaker of the heart. It's located where the superior vena cava meets the right atrium, and it has what's called an intrinsic rate of 100 beats per minute. That 100 beats per minute is actually reduced back by our parasympathetic cardioinhibitory center of our brain. It backs us back down to about 70 to 80 beats per minute. Our SA node spreads that wave of depolarization. It does it through those internodal pathways, through the atria, and it triggers atria depolarization and then down to the AV node. So that atrioventricular node is under control of the SA node. SA node sort of starts it, and then it goes over to the AV node. Okay. Now the bundle of His, we're going to find that that depolarization wave is going to pass along the interventricular septum, which is the center between the ventricles. And it's going to get to the apex of the heart, and then we're going to get to the outer portion of the heart, to those Purkinje fibers. If the SA node doesn't work for some reason, the AV node can take over, but the AV node doesn't beat quite as fast as that SA node, so it's about 60 beats per minute. If the SA node and the AV nodes are both inoperable, the remainder of the conducting system can only generate a depolarization at about 30 beats per minute. 30 beats per minute is ineffective for adequate cardiac output, and so we would have to insert a pacemaker. So here is sort of showing what's happening right here. This is our heart sort of at rest, okay? Then we're going to get our SA node firing, and we get an atrial depolarization. We get what's called a P wave. Now we're here at atrial contraction, and the AV node, the bundle of His, the bundle branches, the Purkinje fibers are all going to fire, and we get what's called ventricular depolarization. This is called a QRS complex. You can see we started at P, we went QRS. Guess what comes next? We're going to get to T. So now we're going to have ventricular contraction and then ventricular repolarization, or our T wave. So an EKG is actually monitoring the electrical activity of the heart. So here you can see there's the P wave. This is atrial depolarization. QRS complex, this is where we're having ventricular depolarization. And then we have our T wave there for ventricular repolarization. So for as far as our cardiac physiology, we know that mechanical follows electrical. So all of those mechanical events that occur during one heartbeat take about 0.7 to 0.8 seconds. Both of those atria and the ventricles are going to contract and relax together. Okay? And so you can see here, this is our cardiac relaxation happening. Then we're going to get a cardiac contraction. Okay? That's going to create heart sounds, blood pressure, and blood flow. Okay. So we get that electrical stimulus at the SA node. That's going to distribute through the conducting system, which is going to generate our EKG, or electrocardiogram. Okay. And that creates the heart sounds and the blood pressure and the blood flow. This is just another showing of that cardiac cycle. Okay. So the P wave, okay, here's the P wave. During the P wave, we have our atrial depolarization. Then we have our QRS complex or interval. We have ventricular depolarization. We have what's called isovolumetric ventricular contraction. We have isotonic contraction, and then ventricular ejection happening. And then we relax back down for our T wave. This is sort of showing you everything that's happening all at once. So this is what's happening in the atria, and this is what's happening in the ventricles. Now, so just so we're clear, we're actually, when we measure blood pressure, we're measuring here sort of along the ventricles. So when the ventricles are in the diastole or the systole. So what's open, what's closed, what phase are we in, and what sound do we hear? Okay, so we have this lub-dub sound of our heart beating, and we're usually hearing that due to the AV valve closing or the AV valves opening. So cardiac output is actually a measurement of the amount of the blood pumped by each ventricle in 1 minute. 1 minute. So the way that we get cardiac output is we take a look at the heart rate. So this is the number of contractions per minute. Heart rate, we're taking here at about 75 beats per minute. Okay. Stroke volume is the amount of blood pumped by each ventricle per minute. Okay. So stroke volume is how much blood can I pump, okay, by each ventricle. So in this case, we say that it's about 70 milliliters. Now we're calculating by milliliters, but we need it in liters, so you have to convert milliliters over to liters before you can multiply. I think it's 0.07. So 75 times 0.07 is 5.25 liters per minute is an average cardiac output. What are some different factors that can influence our cardiac output? First is heart rate, autonomic innervation. Remember, we have the cardio inhibitory center that's going to sort of lower down our heart rate to about 70 beats per minute, right? So even though we have an intrinsic rate of 100 beats per minute, we're not doing that. So we're lowering it back down. Hormones can affect our heart rate. Fitness levels, age, even our ion concentration can affect our heart rate, okay? How fast is our heart going to beat? Factors that can affect stroke volume are how big is the heart, okay? Stroke volume is end diastolic volume minus end systolic volume. What does that mean exactly? If you took a water bottle and squeezed, like if you took the top off of a plastic, sort of silly plastic water bottle and sort of squeezed it, then water would come out of the bottle, right? But you don't really know how much came out of the bottle unless you do a little bit of math, right? So you can see what's still in the bottle and what the total amount the bottle could hold. Hopefully that makes sense, right? So I take what the total amount the bottle could hold, let's say 500 milliliters, and what's left is 300 milliliters. Then that would mean when I squeeze the bottle, 500 minus 300 is 200 milliliters. Okay, so that's how much I squeezed out. And that's what we taught with stroke volume. How much did we squeeze out? Okay. So heart size, somebody has a larger heart, potentially they're going to have a higher stroke volume. Fitness levels, gender, contractility, how much am I able to contract? Am I contracting really tough or soft, right? If I squeeze that bottle really hard, am I going to get a lot more out or a little bit out? Okay. Preload, so what's in the heart to begin with, and afterload, what kind of resistance do I have? So for autonomic innervation, we have the cardio-acceleratory center and we have the cardio-inhibitory center. The cardio-acceleratory center, just like it sounds like, it's actually raising the heart rate, and it does that via the SNS, or the sympathetic nervous system. It increases our rate of depolarization and shortens our repolarization, hence the reason that we can raise up that heart rate. The cardio-inhibitory center we actually do via the vagus nerve. It lowers our heart rate via our parasympathetic nervous system. Okay, so it actually binds, we have acetylcholine is going to bind to some receptors. That's going to open up those potassium channels, and that slows the depolarization and it extends out our repolarization. If you don't remember repolarization and depolarization, be sure that you review action potentials. So hormones that can increase our heart rate. How fast is our heart pumping? Epinephrine and norepinephrine. That would make sense, right? Sympathetic nervous system. Also T4 and T3. These are our thyroid hormones, thyroxine and triiodothyronine. Those are going to increase our heart rate. And then cortisol, which is sort of our stress hormone. But none of them are going to lower our heart rate. Now, there's different ion concentrations. So we can have hyper or hyponatremia. Now, the sodium can actually compete with calcium. So if we have a hypernatremia, that means that we're going to decrease our calcium uptake. And hyponatremia can cause Addison's disease. If you don't remember what that is, review the endocrine system. Hyper and hypokalemia, and then we have the potassium is necessary for repolarization of the heart to bring us back to repolarize, right? So when we have a hyperkalemia, our resting membrane potential becomes less negative, meaning we're at 60 millivolts instead of 70, right? And because we've become less negative, it's easier for us to depolarize, and it can actually decrease or block our repolarization. During a hypokalemia, meaning too little potassium, the cells become less responsive and the heart can actually stop beating. Hyper and hypocalcemia has to do with our plateau phase. So our hypercalcemia means we're going to get a stronger contraction. Hypo means a weaker contraction. So let's talk about that stroke volume a little bit. End diastolic volume is the amount of filling of the ventricle by the end of diastole. So when are those ventricles relaxed? What are we getting in there, right? So we filled up that water bottle. End systolic volume is the amount remaining in the ventricle at the end of the contraction. okay, or after systole. So the stroke volume is the amount that's been ejected. What did I get out of the bottle? Okay. So to increase our cardiac output, we can increase our stroke volume and increase heart rate, right? Because cardiac output equals stroke volume times heart rate. Meaning, if I increase one or I increase the other, I can therefore increase cardiac output. Okay. So in healthy people, hopefully you guys are all healthy and young. I'm a little bit older, hopefully still healthy. My heart rate, our heart rates can increase to about 150 beats per minute during exercise. But we also increase stroke volume, right? Have you ever been exercising? I don't tend to exercise a whole lot, but you're exercising and you maybe feel like your heart is beating a little bit harder. Maybe you can feel your heartbeat within your chest. So that's going to increase our stroke volume because the contractility of the heart is stronger. And so that's going to increase our stroke volume all the way up from 70 to 130 milliliters, right? So this can increase our cardiac output to about 9.5 liters per minute. That's 4 to 5 times our resting rate. So to exercise can actually increase that stroke volume, right? So it increases our end diastolic volume. We haven't really talked about a whole lot, but the way that the blood actually gets back into your heart through that the vena cava, right, is that it has to travel through our veins. Our veins actually have little valves within them, and as our skeleton or our skeletal muscle presses on those veins, it pushes the blood back through the veins to the heart. It's called skeletal muscle massage. And so we compress the veins and it pushes more of our venous blood back into the right atrium. That's going to increase our filling up. Okay? We can also decrease our systolic volume. So when we contract more or harder, okay, we do this through epinephrine and norepinephrine that's released while we're exercising. And we can increase our cardiac contractility because less is left behind in the ventricle. So here's that skeletal muscle massage I was talking about. So as our skeletal muscles contract, they're going to compress on the vein and it's going to move the blood up over these valves that are found within their vein. These valves are sort of like the semilunar valves, and they're one-way valves that can prevent backflow within the vein. So how can we affect that stroke volume with exercise? Remember, we increase skeletal muscle massage, thus we increase our end diastolic volume, and we increase our cardiac contractility, so we've decreased our end systolic volume, and together that means that we increase our stroke volume, and when we increase our stroke volume, we increase our cardiac output. The hypothalamus is also going to trigger our adrenal gland medulla to release epinephrine and norepinephrine. That's going to increase our SA node firing to increase our heart rate. So now we've increased our heart rate and we've increased our stroke volume. Therefore, during exercise, we have increased our cardiac output. So other factors that can affect our heart rate, we have an increased heart rate because of elevated thyroid hormone, so hyperthyroid. Caffeine can do this, nicotine can do it, amphetamines can do it, and even age is an increase of heart rate. So infants actually have the fastest heart rates. Decreased heart rate with sleep, hypothermia, sedatives, narcotics, and acidosis and alkalosis, which we'll talk about when we talked about the respiratory system. So after exercise at rest, the parasympathetic nervous system is going to bring everything sort of back to normal, right? Rest and digest. And remember that cardio-inhibitory center within the medulla oblongata is going to slow our heart rate from the 100 beats per minute back to normal. And our cardio-inhibitory center, again, is active at all the time. So we slow that SA node from 100 beats per minute down to 75. Okay. So what's a heart murmur exactly? A heart murmur is called a valvular regurgitation. And this is going to happen with a leaky valve. So the blood's going to regurgitate back into the chamber from which it came. We can have what's called a mitral valve prolapse. Remember that mitral valve is the bicuspid valve, and it's pretty common within women. So the valve will actually be bent backwards, and we require prophylactic antibiotics to help treat that. And valvular stenosis means that there's a narrowed or obstructed valve. Congestive heart failure, here you can see this. This is a normal ventricular chamber here. This is a thickening of the ventricular chamber. And so with a thickening of the ventricular chamber means that we're going to have smaller filling capacity and injection of the blood. This is a chronic disease because the heart loses its ability to adequately pump the blood. It can be caused by coronary atherosclerosis, which is a filling of plaque and a hardening of the coronary arteries, persistent high blood pressure, and multiple myocardial infarctions, which means a heart attack. The blood can actually back up into the lungs, so you sort of feel like drowning almost, and the right side of the heart gets weakened by the blood backing up into the systemic circulation. So what I'd like you to be able to do is explain that cardiac conduction system, the cardiac cycle, cardiac output, any factors that influence cardiac output, the effects of exercise and cardiac output on heart rate, and the centers of the brain that control the heart rate, and describe their functions. If you have any questions, you guys know where to find me. Thank you.